and welcome to the December Education Through Association series, in which TAFM is presenting different topics to our membership each month. This month, we are honored to have three highly experienced speakers with us, and for the next hour, we'll be hearing from each one of them on infection control measures and best practices that have been implemented within their own facilities. Our speakers include Bang Klein with Memorial Hermann at Memorial City Medical Center. She is an infection control preventionist. We also have Faris Zabanath, who is the Director for System Infection Control Prevention at Houston Methodist System Quality and Patient Safety. In addition, we have Chen Koi, who's the Assistant Director for Infection Control for Texas Children's Hospital System. I want to thank each one of you for joining us today. First, let's hear from Bang. Bang, let's go to the basics and advise on droplets versus airborne. And also, what your facility has implemented or recommended with regard to infection control practices.
Sure, thanks, Alan. And thank you for inviting us to be here today. We hope that you can find a lot of our discussion today is helpful to you as we try to navigate through this pandemic together. And so before we get into discussion about, negative pressure rooms and all of that, I think it's important to just go back to basics as to how this virus is transmitted, droplet versus airborne. And I think that would help you kind of gauge, what type of patients are coming into your facility and help you gauge, when is it necessary to have a negative pressure room for these patients. So there's still lots to learn about this virus. But most of the research out there is showing that the main mode of transmission is through droplet, respiratory droplets, like the virus is contained within these droplets. There's not a whole lot of evidence that these particles are, suspended in air for a certain amount of time. There's just not a lot of science behind all of that at this point. So you'll find that the majority of our COVID positive patients really don't require the negative pressure rooms as long as they're not undergoing any aerosol generating procedures. And so at least at our campus, most of our COVID patients are going to be found in our med-surg units, and those patients are put in regular patient rooms, and the appropriate PPE that you would wear is a surgical mask, eye protection, gowns and gloves for those patients. Now, for patients that have aerosol generating procedures, they're being intubated, they're on BiPAP, they're on Vapotherm. A lot of our critical care patients or ICU status patients will likely require the negative pressure rooms. And so that's kind of a different level of care where, you're having to wear the N95 mask and ensuring that there's negative pressure. So I would just highly recommend that you, connect with your administrator or nursing leaders to kind of gauge what your patient population looks like for your facility, just so that what type of volume you actually need for your specific areas as far as negative pressure goes. So in our patient care areas, especially during our surge and our peaks in COVID volumes, we worked really closely with our facilities engineering team to create more negative pressure spaces, particularly in our ICU areas. And so the biggest thing with that is we brought in HEPA filtration units for these areas. So we asked the team to ensure that they're changing out filters, based on manufacturer guidelines. I know those pamphlets are not fun to read, but we got to adhere to them, okay? So we've got a team that goes around, after a COVID patient's discharge, they're assessing the unit, making sure all the filters are being changed out appropriately. We actually asked our facilities engineering group to create ante-rooms outside of these negative spaces. Although that's not a requirement, that was actually a request from our nursing staff to have ante-rooms built into the hallways. And really it's just to help them visualize, like, okay, this is a COVID patient room. Kind of gives them a staging area to properly don and doff PPE. Anything that comes out of the room is being wiped in that area as well. So we found that it was helpful for our facility to have ante rooms built. at the beginning of the pandemic, we weren't sure how long this was going to go on. So it was actually made with, the typical plastic construction barriers. And as time progressed, those did not hold up. So if you are going to build an ante-room or something like that, we definitely would recommend making it out of the more durable Cortex type of material. It's cleanable, it lasts a lot longer. And we ask our teams to actually assess it very frequently and make sure that there's no penetration in any of that. So that's kind of what we've done on our inpatient units. At the height of the surge, we actually did cancel our elective procedures, but there was a need to have more ICU beds. So in that situation, we actually had our day surgery PACU area that was available to us. So we turned that entire area into a negative pressure area. So that's through working with, again, looping in our facilities engineer. We had, third-party contractors and engineers come out to assess that area. And so it was definitely outside the box, converting that entire PACU area into essentially an ICU surge area. And we were lucky in that it was on the first floor. There were windows that were available to us to knock out to accommodate negative pressure machines. We also created walls and barriers to separate the hallways from negative pressure, completely separated from our ORs. And so that was something that we had open for several weeks during the summer, during the surge. The landscape now looks a little bit different because I think a lot of healthcare organizations, canceling elective surgeries is going to very likely be a last resort. And so I don't know that we would be opening that area again. Hopefully not, knock on wood. But that was another strategy that we used to be able to accommodate, the surge that we had over the summer. And so I guess that's all I had for the negative pressure areas. And of course, we worked really closely with facilities engineering on our screening stations as well, ensuring that we're limiting and monitoring our points of entry. So we have quite a large campus here with multiple ways for people to enter our campus. So we've had to close that off, lots of signage. We had a lot of security presence at the beginning of all of this to ensure that we've got traffic flowing straight to our screening stations and not having anyone wandering around the campus without being screened. We encourage social distancing. We had to remove chairs from waiting areas in our lobbies and all of that. Lots of signage to encourage masking, hand hygiene, and all of that. So those are just a couple of things that we did on our campus specifically in response to this pandemic. So I'm going to hand it off to Alan or Faraz. Y'all had any questions about that?
When you set up your windows, you use templates in place of the window?
The template, what do you mean templates?
Wooden template, plywood,
Oh, yes.
R-rated type.
Yes, that's what we use. Mm-hmm. And we kind of lucked out that it was on the first floor where we were, so we were able to be able to do that. There are some areas, on higher levels in the hospital that, we not might be able to accommodate that. But luckily for our PACU surge area, we were able to do that.
Faris or Shin, is there anything you would like to add to that?
Not really. I think a lot of organizations have gone through very similar setup as far as negative pressure and all of that. But here at Houston Methodist, we did it a little bit differently. And the reason is because, as many of you know, we have 8 facilities in the Houston metropolitan area. One of them happens to be in LTAC. And we have a lot of space in the LTAC that is not being used yet. So what we did right at the beginning of the pandemic, or actually before, was even declared to be a pandemic. We engaged facilities engineering, we've engaged engineers as well. We looked at the empty areas of the LTAC that we have, that we previously set up as a highly infectious disease unit for preparing for Ebola patients, and we looked to see how we can expand it. And in that, what we did is we converted about 20 rooms into negative pressure rooms to be able to house acute care patients that might require airborne isolation because they're on high flow oxygen or any type of aerosol generating treatment. And the reason we did that is because we wanted to make sure that we are able to decompress some of our facilities, because we knew we were going to be getting a lot of patients. We were monitoring the situation in China for quite a bit of time. I mean, it came to our attention at the end of December. We were monitoring continuously on a daily basis in January, February. But that's something that is kind of unique to Houston Methodist, and the reason is because we have an infection control specialist that monitors the emerging infectious disease alerts throughout the globe on a daily basis, just to make sure that if there is any chance that something like this will be a possibility for the U.S., that we're able to react to it. In 2018, when the Ebola outbreak happened in the Democratic Republic of Congo, DRC, we actually took action at that point to make sure that our highly infectious disease unit is in our LTAC facility is set up and ready to go. Of course, with Ebola, you're not anticipating a mass amount of people that are going to require it. So we had an option of expanding and contracting that unit from 1 to 2 beds to about 20 beds. So we had an advantage over there, and we started preparing for that. In 2018 through 2019, actually, the Ebola outbreak continued in DRC, and we were always getting ready for that. We started stockpiling some of the PPE that we would require for taking patients in, and that, of course, includes the respiratory protection devices and so on, which helped us a lot for when we converted to now COVID. So once we looked and expanded that unit, that actually allowed us to transfer a lot of patients to what we call HIDU, or highly infectious disease unit. Another thing that we did is we looked to see how we can expand that even further. So we expanded it to 2 other units in that area. One of those units we never really used very much, but definitely one of the bigger units, which had 23 beds, we were able to transfer patients and decompress a lot of our inpatient beds here at Houston Methodist and all of our hospitals. But that took a lot of coordination between facilities, engineering, capital projects, infection control, and so on. So it became very obvious then that any silos that existed before came down very quickly. I learned a long time ago, since I started infection control in the field of infection control, that one group in particular that you must make your best friends are the facilities engineering people. And that's because you're going to rely on them a whole lot in incidents like this. They are the experts in HVAC systems, air exchanges, filtration, and so on. So very early on in the pandemic, we had already had a meeting with facilities engineering to figure out what type of filtration we have throughout our hospitals, what type of air exchanges we have. Are we able to change the air exchanges to bring in more fresh air, and so on. Later on in the pandemic, now that we're thinking outpatient, we also tapped into the facilities engineering to understand more about air exchanges and filtration and HVAC requirements and all of that in the outpatient settings, as you would know, in MOBs and so on. So a lot of that work was done ahead of time so we were able to take action. I think Bang talked about negative air and what the requirements are and all of that very nicely, Bang. Thank you. But one of the things that we have to make clear is that you can change everything to negative pressure. You can buy all the negative pressure machines that you have and all of that. The problem is that if you convert too many areas in your facility into negative pressure areas, you really are putting yourself at risk of unintended consequences in terms of the building pressure, moisture intrusion, and so on. So you have to be really careful and balance what is being said in the guidelines and what actually is happening on the ground. The CDC has come out right from the beginning and kind of went back and forth as far as airborne transmission and so on. And what we did at Houston Methodist is, rather than just relying on the CDC guidelines to tell us what the requirements are, we actually looked on a global level. We looked at other guidelines, the Canadian guidelines, the Queensland guidelines from Australia. We looked at the WHO guidelines. We also looked at scientific evidence that is out there to see, is it something that we have to worry about in terms of regular patient care? Now, keep in mind that airborne transmission is possible under certain conditions. And the conditions that Bang talked about very eloquently is when patients are going through aerosol generating procedures, such as nebulizer treatments, high flow oxygen, and things like that, and that sort of treatments. But you also have to look at the timeline for the procedures. What type of procedures are they? Are they intermittent breathing treatments or are they continuous? So for instance, with high flow oxygen, we know that's a continuous aerosol generating procedure. But then you have to look and talk to the experts about what is in high flow oxygen is aerosol generating. Is it 6 liters? Is it 25 liters? What is it? So from there, we adopted the 6 liters and we decided that any patient that is on 6 liters or above would be classified as aerosol generating treatment, and therefore they would require negative pressure room. So we placed them in negative pressure rooms. And those patients actually went on airborne plus contact isolation. For patients that needed intermittent aerosol generating procedures, such as nebulizer treatments and things of that nature, we actually placed them on a modified droplet isolation plus contact isolation. For patients that did not require any aerosol generating procedures, we put them on just regular droplet isolation plus contact. But you also have to look at the other patients that are coming into your facility, because you have to be aware of what they have to go through as well. We don't know whether those patients are positive or negative. They're not showing any symptomology that is consistent with COVID, but we all know that 40% of people that get COVID are asymptomatic. So at Houston Methodist, what we instituted is that every patient that is admitted has to get tested for COVID. And if they're negative, then we don't have to worry about aerosol generating procedures at that point, but we also have to retest them every 14 days to make sure that if there is a patient that came in during their incubation period and we missed that positive, that we're identifying them within that timeline and administering the proper precautions at the time that we are doing the aerosol generating procedures. So any patient that we were not able to do testing for, of course, we assumed that they could be positive. We didn't place them on isolation because that's not what they were admitted for, and they're not exhibiting any symptomology of COVID. but we took the same precautions when we cared for those patients as we would do for an assumed or a positive COVID patient. So we had to build a lot of algorithms, and so that the staff know when to do this and when to transfer patients to negative pressure rooms and so on. So as far as facilities are concerned, we did a lot of preparation right from the beginning. One of the things that our facilities engineering department helped us with in preparation was how do we lock down the area in collaboration, of course, with security. Because as Bang mentioned, our facilities are huge, especially here in the medical center. We have entrances from everywhere, including from other facilities like from PCH, from Memorial Hermann, from St. Luke's, and so on. So we have to make sure that we are diverting all of that traffic into areas where we can actually control traffic and do the appropriate screening on anybody that is coming in. So facilities engineering played a huge role in doing this, locking down, putting barriers to control flow of traffic, and so on. But another thing that they helped us with is social distancing. Bang mentioned something about removing furniture, but in addition to that, we had to put signage up on the floor and on the walls. We had to change the care settings a lot of times, as one of the other speakers mentioned, by turning rooms into negative pressure rooms. Now, keep in mind that in some facilities, we're not able to take out the windows very easily. So how do you do negative pressure in that case? What we did is when we were not able to open windows and diffuse the negative pressure through to the outside, what we did is we diffused it to the inside in common spaces, but we double HEPA filtered the negative pressure. And this way, we knew that we had a HEPA filter in the machine, but we also put a HEPA filter in the ceiling where the air is being diffused. This way, you're capturing any possibility of pathogens going through the first HEPA filter, but not through second HEPA filter. Building anterooms is a great idea. In certain areas, you're able to do that. And as Bang mentioned, you really have to look at maintaining that. Regular plastic is not going to do it. 6 mil plastic is going to tear up. Cordex with actual studs would be the best way to go. Then you're able to control it, clean it, and so on. But one of the things that you have to look at is the negative pressure machines. You have to have enough capacity in those negative pressure machines that you are moving enough air to create enough negative pressure. And you have to also make sure that you're not over pressurizing areas and making it way too negative where barriers start coming down or lay-in ceiling starts coming down and all of that. So you have to be really careful and balance it very, very carefully. Another way of that we went with is the converting some areas that were not necessarily abandoned, but we haven't used for a while, because now that we have new buildings, we've moved those patients to another areas. So we took one of the ICUs that was recently evacuated into a different area or new building, and we turned that into a high flow, highly infectious disease unit, where all the patients that are in that area are on high flow. Well, we know all of them have COVID, so you're not trying to prevent them from getting COVID. So they have to be confirmed to have COVID. But you also have to look at how can I control the massive amount of people that are coming in and put them in areas where I can care for them properly and convert that area into a negative pressure room. So we made in several of our facilities, we turned areas into high flow oxygen areas. But another thing that you have to look at is, with the shortages of the PPEs that we've started experiencing before, how do you maximize the usage of the PPE that you had? So we actually looked at it, and we decided that one of the things that we might want to practice is it's much like we do with Ebola, where you have zones. You have the hot zone, the warm zone, and the cold zone, where people in the warm zone can use extended use PPE, where they still have the certain things on, like the pure flows or the PAPRs, not necessarily the gloves. Of course, you have to remove the gloves, but the gowns, if they are not visibly contaminated or have come in contact with anything, you know, their shoe covers and so on, so that they are not removing it every single time that they're coming out of the patient's room. So we did a lot of that, where we converted areas into what we classify as HIDU areas, highly infectious disease areas, where now we are able to use the PPEs for an extended period of time. Another thing that facilities helped us with is looking at the reprocessing of PPE, especially the masks. We started with the N95 masks, reprocessing those. And when you reprocess N95 masks with the current methodology, which is the hydrogen peroxide vapor, you have to control the airflow in it. So we built actually a chamber where facilities engineering helped us build to where now we are able to have a designated area for clean, dirty, and intermediate spaces, where we're moving those masks from one area to another, so that when the end product is completely clean, disinfected, where we can package it and send it to the person that wore it previously. So much of that was done in collaboration with facilities engineering. I want to go back to negative pressure room and the negative pressure machines, just to make it very clear. And Alan, you can stop me at any time if I'm rambling on too much, please. But with negative pressure machines, you have to be really careful, because those negative pressure machines are not intended to be used as air scrubbers. Those negative air machines are intended to be used as creating negative pressure in one area, positive pressure in another, or if you dump it outside, of course, just the negative pressure inside that room that you want to make it negative. They're not intended to push the air from one area to another in the same room. And the reason is, and you have to be really careful about this, is that now you're taking air that is being generated and just shooting it to the other side of the room. And you're creating so much turbulence, so that if there is any aerosols that are being generated, you're actually keeping them in the air for a longer amount of time with all of that turbulence that you're putting in. If you're going to put a negative pressure room in there, use it as it is intended. And that's to take air from one area, clean it, and push it into another area. And do not create any turbulence in the room, especially in a COVID room. One of the things that you might want to think about is an actual air scrubber or air purifier that does not cause a lot of turbulence, but you can station in an area where it can clean the air and not cause a lot of turbulence, and kind of purify the air inside the room if you're not able to create negative pressure. One other thing that facilities engineering helped us with is when we started running out of the certain number of PPE, we started looking at how do we sustain without having to rely on, for instance, gowns. We built a personal protective pod that we are able to go in the patient's room without having to put a gown on, to turn off switches or position something, not necessarily the patient, so that if we don't have to have close contact with the patient, we're able to go in, come out, and be safe at the same time. We've built collection devices. We've built intubation boxes when negative pressure with alpha filtration. Many different things that facilities engineering was able to help us design and also manufacture. One of the things that we're working on right now is shields in pathology areas. Many of you probably know that as a teaching facility, we use a lot of scopes with multi-head scopes, where those heads are actually very, very close together. And you can't wear a shield when you're trying to look through a microscope. So we worked with our facilities engineering to create partitions or shields between the heads so that we are able to have students look at those microscope heads and be able to be in close proximity to each other, because in that instance, you're not going to be able to do a lot of social distancing. But like I said, the outpatient setting was very unique in terms of converting some of the exam rooms, exercise rooms, and so on into negative pressure rooms, much like we did in the hospital. One thing that I'm going to encourage everybody to really look at. I know that the CDC, everybody looks for the CDC to guide us, which is great. But the problem sometimes is that even the CDC does not have the appropriate information yet, or they keep changing it from one day to another. What I would ask for everybody to do is to do your own research as well. Look at peer-reviewed studies that have been published. Even if they're not peer-reviewed, there is some validity to them. Look at the science behind the recommendations of the CDC and make sure that it's sound science before you jump into a practice that may not be reliable. That's really all I have.
Well, thank you so much. That's very useful information. I would like to turn it over to Chen now to get his perspective on what we've been doing here at Texas Children's.
Sure, Alan, thank you. It seems like both Firas and Bang have covered most or the majority of the story regarding the negative pressure room patient placement. So I just want to add a couple of things based on from the perspective of children's hospitals, because majority of our patients are the children's hospitals here. So what we did at the beginning of the pandemic, we have the highly infectious unit in West Campus, or we call it a special isolation unit, or SIU, which is similar to the one that Firas was describing. And so what we did actually during that time, we transfer every patient with a COVID or COVID suspect, or we call it the PUI, to West Campus. That's during the beginning of pandemic. We are pretty lucky, I will not call it lucky, but we are pretty fortunate in the way that with the children, most of them, we have a high positivity rate. However, the admission rate is not as high as the adult. So we are able to do that process by transferring all our patients to West Campus. But during the height of the pandemic, we realized that it's not possible anymore. So what we do actually different is like we start setting up the cohort unit in every campus that we have. So we don't put the COVID patient in different places. So there's like specific unit that will be handling positive COVID patients only between the acute care and also the critical care. One thing that I agree with Firas also, we do test every patient on admissions before surgery. So basically we are aware of their COVID status on admission. So the need of negative pressure room is not really high again for our facility here because we know the status of our patients. In addition to that, we do not have the anteroom like the way Bang was describing because we thought, well, this could be droplet most likely also. So what we did actually outside the room, we kind of like setting up with the tape on the floor, kind of like indicating the people that it's almost like a warm zone, like Firas said, like so people can step on that, but they still have some PPE that they use, but they're not really supposed to step out of that. That's how we call it, almost like anteroom, but there's not really an actual wall, just a lot of them imaginary wall than anything else on that one. So that's the difference. And we do not decontaminating our N95. I know that is like a precious item for all of us at that time. So what we decided actually, we are extending the use of N95 in our facility. So they are allowed to use the same N95 for the whole shift or the whole day, as long as they cover it up with a surgical mask on the top of it. but they have to replace the surgical mask every time they leave the room. So, so that's how we preserve the N95 for our patients, basically. In addition, with that N95, we also have some doctors or even nurses that will not fit. Even when we do fit testing, they do not fit in any of the masks. So we have like 5, 6 different type of N95. They cannot be fitted with any of them. So also we have the capper or the control air purifier that we bought, several of them for this staff to use when they cannot use N95, basically. What else that I have in Children's Hospital? Air scrubber, Viras mentioned, some of the doctors in the clinic especially, they do think about, they want to have something like that. So we're still looking into purchasing that, or should we buy that? They have a concern because like the clinic patient, we do not test them prior to the admission to the clinic or prior to being seen in the clinic. So there's some physicians are concerned about this type of patient, even though they don't have any symptom consistent with COVID at all. Regarding the screening, we all have the same issues. We have so many entrances from every building here. So we try to, like Firas and Bang probably mentioned, we have to close a lot of entrances so we be able to control them. The other thing also, we have to try to separate between patients and staff. So we have different entrance for the staff and different entrance for the patients, so we don't mix them together. I believe that's all I have to add to that, Alan.
Well, thank you so much. I appreciate that. I do have a few follow-up questions. One of them is that there's been some talk about PFT, perfusion rooms, and due to the fact that there is a lot of, as what Firas had alluded to earlier, there's a lot of droplets that can be into the air that through aspirations of that. Have any of your facilities done anything such as ultraviolet lights that can also be used for cold disinfectant, but if they're put in a certain position, they can also become airstream disinfectant as well? Has any of your facilities accommodated any of this?
We have not used. I mean, what we do is we use UV light for disinfection of the rooms after the patient is discharged, whether it be in the ORs or if the patient has a particular disease like C. diff or norovirus or one of those what we call enteric isolation organisms. We have really not used any UV light for disinfecting airstreams. And the reason for that is because we simply don't believe in it. And the reason I say that, because scientifically, it really is not sound. And the reason I'm saying that again is that UV light needs enough contact time to be able to kill organisms that are flying through. And for that, particles are moving in the air very quickly. So you can't really have enough contact time with UV to be able to either deactivate them or kill them, knowing that a lot of that air is basically recirculating. So unless that particular particle hits the UV light for a significant amount of time, you're really not disinfecting the air, basically. You're disinfecting surfaces, and it's whatever the UV light sees, like countertops, beds, and so on, but not necessarily air.
Well, thank you for that. Bang or Chen, do you have anything you'd like to add to that?
I can add a few things, Alan. Like Firas mentioned earlier, we cannot just use like one data source on anything like this. So, some of our physicians basically think that PFT or pulmonary function test is considered high aerosol generating procedures, but from what we can tell, it is not truly aerosol generating procedure that's defined even by the CDC. So we try to do the minimum allowance. Basically, we change the filter to make sure at least it's at MERV 13 or higher in our exam room that they've been doing the PFT test. Actually, the other thing that we recommend actually, as soon as the patient is done, that they leave, we tell them to go ahead and leave the room vacant for an hour, even though we don't think it's that necessary, but we tell them to go ahead and leave in an hour before they place another patient. But we don't have anything additional. And I've been talking to my physician, the pulmonary physician, to see if they have any recommendations from their foundations, even like CF Foundation regarding a PFT. And at this time, they said they have not come up with any recommendation about how to treat this type of patient. So we just go, but like I said, we don't use the UV light in our hospital to decontaminating anything. It's just regular cleaning, the correct appropriate filter in the room, and leave the room for an hour before the next patient. That's all we've been doing.
Very
Alan,
Thank you,
similar.
Jen. Bang, would you like to add anything?
Yeah, it's
go ahead, Bing.
both for us and Chin, we have very similar process here at Memorial Hermann as well. We have UV disinfection, but that's currently only being used, after a full thorough terminal cleaning of the area. So that doesn't negate the importance of proper manual cleaning, right? So we're using it for COVID spaces after patients are being discharged. So that's the area that we're using UV technology. As far as places like our OR, we don't have a negative pressure OR for this particular virus. There aren't requirements, to my knowledge, that procedures have to be done in a negative pressure area. So what we've resorted to is a table that we got from our CDC resources that talks about the amount of time it takes for a specific amount of air changes per hour in that space. That is sufficient enough to remove airborne contaminants at 99% efficiency. So based on whatever the air changes per hour in any particular space, we leave that area vacant for X number of minutes before, we roll another patient into that area. So that's kind of how we've worked around kind of those areas that might, where we get some pushback from clinicians about wanting air scrubbers. So again, it kind of goes back to the science and really explaining that to them and making sure that they're understanding the science behind, the proper ventilation and proper filtration of these contaminants.
Well, I want to thank each one of you for taking your time out today to present for our TAFM members and our membership, and so they can learn what other organizations, other hospitals are doing to provide the best possible care for their staff, their patients, and their visitors. We definitely appreciate it. There is some resources available out there. One of them is through TAFM, of course, ASHI, and then ASHRAE 170 is also what the CDC is using as a standard for a guideline. ASHRAE and all three organizations are working very closely together to provide the best patient care possible for prevention of the spreading of the COVID disease. But again, I thank each and every single one of you for taking your time out. I hope you have a wonderful holiday. And again, thank you so much.
Thank you.
Thank you, Ellen. Stay safe.
Thanks for inviting us, Ellen.